at Atrium Health in Cabarrus. He had just finished the Trauma and Acute Care Surgical Fellowship here at Atrium Health in 2022 and has joined the faculty right after his completion there. His education is actually medical education was in Canada, got his medical degree at McGill University, went on to an internship and residency at the University of Ottawa, and then performed the Surgical Critical Care Fellowship at Duke University prior to coming to Atrium Health to finish the trauma/acute care side of this. His lecture today is on blast injuries. We don't see a tremendous amount of these, but the knowledge of this is going to be very critical as when we do experience them, they are typically come in groups, unfortunately. Dr. Lau, great to have you.
Thank you, Dr. Singh, and thank you all for taking your time out of your busy day to attend this talk. I'm hoping that it'll be a fun lecture with some stories, and I will tell an incident that is a little bit close to home at the end of this. So, welcome to the Crash Course Trauma on Blast Injuries today. So stop me if this seems familiar. It's just another day and you are counting down the hours to shift change, which I will never admit to as a fellow because I was hardworking. But it is a long day. There's nothing unusual going on. You're going through the motions. And then all of a sudden, reports of a mass casualty event happening downtown. Now, within the first hours, the casualty will start rolling in. And so as you're assembling in the trauma bay, I'm sure there's a lot of questions you're asking yourselves. What information would you like to know about the explosion? What are the number of anticipated casualties? What type of injuries are you supposed to expect in a blast injury? Are there any chemical, biological, or radiological threats that you are to expect? What specific resources need to be mobilized? And finally, what are some of the foreseeable diagnostic and management challenges? Now, as you're going through all these chaotic thoughts in your head, let's go through some objectives for the talk today. Just remember, keep calm and carry on. Today, we're going to explore and understand the epidemiology of blast injuries. We're going to talk briefly about the basics of explosions, essentially the chemical process of explosive reactions. We'll classify the blast injuries, and then we'll close out the talk by reviewing some specific pathologies that are quite unique to blast injuries, as well as general management guidelines. All right, starting off with some data. According to the US Bomb Data Center, which I didn't know existed until I made this talk, the explosive incident report in 2019 outlined the following incidents happening. In the year 2019, there was a total of 715 reported explosion incidents. About a third of those are classified as accidental, and another third, a little bit more, 251, are classified as bombing incidents. So these are essentially either terrorist attacks or deliberate efforts at bombing. The rest are undetermined or not specified. But of all of these incidents in 2019, a report of 86 injuries in total, including a majority of those were victims, but fire services, law enforcement, and suspects were injured as well. And out of these incidents, a total of 16 fatalities, most of them victims as well. One of the things to note here is that this data only encompasses explosive incidents that were reported to the federal government. So all of your regular 4th of July folks blowing their faces off with their fireworks probably does not catch here. What I'm trying to say here is kind of like Dr. Singh said, this is a rare and unpredictable type of injury pattern, but one that is tremendously capable of overwhelming an unprepared healthcare system. All right, let's talk a little bit about definitions and classifications. An explosion, what is that? Well, at the very basic level, an explosion is a rapid and violent chemical reaction that is accompanied by significant release of energy and volume expansion. Usually, chemical compounds that are able to explode, or explosives, are classified in two broad categories. You have the high-order explosives, or colloquially known as high explosives, as well as the low-order explosives. High-order explosives are defined as those who are capable of producing a supersonic overpressurization shockwave, and these are typically very powerful chemical compounds and traditionally only seen in military context. These are your TNTs, your C4, your nitroglycerin, and your dynamites. In a civilian setting, we are more likely to see explosions out of low-order explosives, and which are essentially any chemicals that are capable of producing large volumes of gases when they are burnt. Now, they traditionally do not explode unless there's a large volume of it, or they are confined into a certain space. So these are the chemical compounds you would typically think of as gunpowder, petroleum, and gasoline-based compounds. So essentially what would happen is an ignition source would cause the combustion reaction to start, resulting in the detonation of the chemical compounds, followed by an expanding blast wave outwards from the source of explosion. Fragments and debris, either from the explosive device or surroundings, are ejected and fly outwards. And finally, once the pressurization wave passes, the low pressure around the explosion causes a returning blast wave. I hope this video works, but this is a great example of an explosion happening in place. I'm hoping you'll pay attention to a blast wave that'll occur, and I'm going to try to pause it and show it to you. As you can see here, this line, that is the overpressurization wave caused by high explosives. And you'll see that it's traveling quite fast towards you. Try to zoom out. All right. So that is explosions in a nutshell, about chemical reactions and all of that. Now let's look at blast injuries classification. A lot of it gets a little bit academic, but hopefully it'll make sense. Blast injuries are, broadly speaking, categorized into primary blast injuries, secondary blast injuries, tertiary blast injuries, and then the quaternary and quinary ones are usually lumped together as miscellaneous. The way I think about it, the way they're classified are essentially in what order are you going to get these effects if you were to be the victim, unfortunately, of a blast injury. The primary blast injuries are usually due to the pressure wave hitting you and your organs directly. The secondary blast injuries are the effects of any projectiles that are thrown by the explosion. The tertiary blast injuries are the result of you being thrown or falling off of any buildings or anything like that from the explosion. And then the miscellaneous are any blast injuries that result from the explosion, either directly or indirectly, but much more delayed in time. Usually things like burns, chemical, biological, radiological exposures, asphyxia, including PTSD. Looking a little bit more into details, let's look at primary blast injuries. Primary blast injuries being an overpressurization wave usually causes barrel trauma from the shock wave interacting with, well, you. So usually your gas or fluid-filled organs, so organs capable of compressing and decompressing, will be the most commonly affected. These are your lungs, your GI tract, your ears, your eyes, and your brain. Really, the degree of primary injury to be expected will depend on a couple of things. Now, note, high-order explosives are required to usually cause a shockwave, and therefore, primary injuries may not commonly be seen in typical civilian blast injuries. But the degree of injuries you have will depend on the type and size of the explosive charge, the distance from the charge to the target. Obviously, the closer you are, the more dangerous it is, and the shockwave through which the medium through which the shockwave is propagated. Now, usually in a day-to-day life, that is not an important factor because air is the medium through which all the explosions happen. But occasionally there are explosions underwater, and water, being non-compressible, is a much worse medium to undergo a blast injury. So what are kind of the unique injuries that are seen in primary blast injuries? You would see typically pulmonary viral trauma, typically known as blast lung. You may also see air embolism. For the ear, you might see tympanic membrane ruptures and middle ear damage, the ringing sensation in your ear. You might have the abdominal viscera perforation. Your ocular globe might rupture, and you could definitely get concussions and traumatic brain injuries. And what's interesting is because it's a pressure wave, sometimes you could get traumatic brain injuries without an apparent external head injury. All right, moving on to secondary injuries. These are typically due to the projectiles, debris, fragments, and other objects that are displaced both by the blast wave and the blast wind. And so these typical injuries will be similar to what we see in penetrating trauma. So either by fragmentation, or if a large enough object is thrown, you could get blunt traumas, resulting in traumatic amputations and all sorts of injuries, and particularly intraocular foreign bodies or globe lacerations. Tertiary injuries, with this beautiful scene from the Hurt Locker, results from the body being thrown by the blast or any structural collapse from a building. And now these injury patterns are more blunt and will be similar to your falls or motor vehicle crashes with significant ejections. These typical injuries will include, your fractures, your traumatic amputations, blunt traumas, your traumatic brain injuries, and crush injuries and compartment syndrome. And finally, the quaternary and quinary injuries, as we are learning more and more about them, and are essentially any injuries or illnesses that arises directly or indirectly as a result of the explosion, but not due to any of the mechanisms mentioned previously. Usually this category is more for academic purposes, but it is something to remember for our patients if you ever see anyone with blast injuries in terms of long-term follow-up. These are things such as burns and thermal injuries, your CBR exposures, the significant psychological trauma of going through a blast injury, as well as exacerbation of any existing medical comorbidities. So that is in broad the blast injury classification. All right, let's move on to some broad treatment strategies. So the first thing to do about blast injuries is they very rarely occur with a single victim. And so we must be prepared to activate the mass casualty plan and mobilize the resources that are available at the hospital. So typically you would be thinking about your trauma team, your emergency department, your critical care, burn units, radiology, blood banks, the usual, not so different from any other mass casualty event. However, there is usually a need to establish security, a decontamination, and a triage area. And the reason for that is, as we saw from the reports by the Bomb Data Center, a third of blast incidents in the United States were actually intentional. And so there's no reason to, let down your guards and think that that would be an isolated event, and there could potentially be more attempts made at the healthcare center. Decontamination is for possible CBR threats. And the type of injuries to expect, according to some of the literature that is out there, and again, this is a mixed data, so take it, cannot really be taken, for single incidents, but the most common injuries seen in mass casualty events resulting from blast injuries are your subarachnoid hemorrhages, your skull fractures, your lung contusions, your tympanic membrane ruptures, and your liver laceration. So as part of the triage, in addition to the standard triage exam and the full body exam and whatever you do for your triage protocols, there is a recommendation in this case to focus and add a tympanic membrane exam, which I'll get to why, focus on respiratory symptoms and hemoptysis, as well as to look for pneumothoraces, which can be hard in the triage bay, but with the advent of more portable ultrasounds and POCUS, this could be a consideration added to our triage protocols. And if you are able to gather information at all from first responders or from government agencies about the explosion, these are some of the data you would want to have in order to get a sense of what to expect. Explosions in confined spaces, inside buildings, inside vehicles, inside the metro station, will tend to produce a lot more primary injuries because that blast wave has no room to dissipate and will ricochet off of the walls, hitting the victims multiple times. Most terror attacks, unless they have access to high order explosives, are usually made with improvised explosive devices. And usually what these people do is they will get, they're unable to get the high explosion that necessary to create a shockwave. So they will try to pack as much junk into the bomb as possible with the idea of inflicting secondary injuries. This was something that was seen at the Boston Marathon bombing, where it was essentially a crude pressure cooker and with a lot of ball bearings and other junk and nails to inflict secondary injuries. If there's a report that an explosion has caused a structural collapse, then you should start anticipating tertiary injuries as well. Finally, once you have all of this set up, the initial stabilization is no different than any other traumas, and we should really follow the ATLS guidelines. All right, now let's go over some management and of these unique injuries that we talked about. Really, the first one I wanted to go through is the tympanic membrane rupture. It seems like a pretty mild thing to consider when someone has been subjected to, an explosion, but there's some diagnostic use to this tympanic membrane examination. So it is a commonly injured structure in primary blast injuries, and the incidence really ranges from 15 to 50% of all the blast injuries that have been studied. and is an injury that's very easy to miss in critically ill patients. As you can imagine, if someone's ill enough to go to the OR, go to the ICU, the tympanic membrane exam may be missed in all of the chaos. The clinical manifestations are very variable. They could be as mild as tinnitus and a bit of hearing loss to complete pain, vertigo, bleeding, and permanent sensory loss is another possibility. So in terms of investigations, this is nothing new. You want to do a full external otoscopic and cranial nerve exam. Once the patient is stabilized, you could consider an auditory and vestibular function exam, as well as high-resolution CT scans if you're worried about any significant associated cranial injuries. The management of a ruptured tympanic membrane is pretty straightforward. Autotopic antibiotics, talk to an ENT surgeon. Most of these will resolve spontaneously, but some of them might need surgery. All right, why do we focus so much on the tympanic membrane, though? It has been recommended in some data, especially the military literature, that the otoscopic exam serve as a triage crossroads for when you are dealing with a mass casualty event of blast injuries. And the reason is because they think that it is a good indicator of potentially worse injuries in someone who may be otherwise normal when they present. So after you undergo ATLS resuscitation, you perform an otoscopic exam. And if the tympanic membrane is intact, there is some recommendation that this patient can probably be discharged or go treat other injuries. If the tympanic membrane is ruptured and all things else being equal, even if this patient is well, there is recommendation to observe this patient for 6 to 8 hours for some delayed presentation of other injuries that we'll talk about. If after 6 to 8 hours, the saturations are normal or the patient's asymptomatic, they can probably be discharged. And if there is decreased saturation, then you should start anticipating primary blast injuries. But this is, this screening for blast injuries has come into question with more and more data coming out of the war in Afghanistan as well as the war in Iraq, as it was previously believed to be a strong marker and predictor for primary blast injuries. And this was mostly based on cadaver studies. It has been recognized that the tympanic membrane will rupture at much lower pressures than the lung or GI tract. But there's more recent evidence to suggest that the overall sensitivity of the otoscopic exam is very low. It's 50%, so flip of a coin. But once you do have tympanic membrane ruptures, the specificity for blast injury is fairly high at 87%. The issue here is that a lot of times tympanic membrane perforations may be underestimated, as a lot of patients who may die in the field from the blast injuries were not examined for their tympanic membranes. And there is reliable data to suggest that once your tympanic membrane is perforated, you are associated with a higher injury severity score, as well as the need for higher resources. So even though there is more data to show that this is not the end-all be-all of blast injury screenings, it is still an extremely useful initial triage tool. Moving on to blast lung injuries. This is due to a major disruption of your alveolar capillary interface and your lung tissue, which are essentially being torn by this massive overpressure. There's variable incidence, with the military quoting about 6 to 11% in recent military casualties. In terrorist attacks that have occurred in civilian settings, such as the 2004 Madrid train bombing, up to 90% of patients had experienced blast injuries to the lungs. The thing with the lung blast injuries is that it is probably the #1 cause of mortality in the field before patients make it to the hospital. The clinical presentation is very variable. You could get things from mild respiratory symptoms all the way to ARDS requiring intubation. And the issue here, much like you'll remember when I talked about the 6 to 8 hours of monitoring for a patient with tympanic membrane rupture, is that the presentation may be delayed by several hours. And so you have to maintain a high index of suspicion. A lot of times, these injuries may also present in a mixed pattern in patients with penetrating injuries as well as secondary blast injuries. So what does it look like? These are very variable. You'll have your scattered petechiae to your confluent hemorrhages, but the biggest differentiator between a primary lung injury, blast lung injury, and one like a lung contusion from MVCs or motorcycle crashes that we see is that a lot of these infiltrates are central, because the thought is that the pressure waves travels through the open airway through your mouth, through your trachea, and then essentially rips apart your lungs from the inside out. And so you'll see this pattern here commonly referred to as the butterfly pattern of the bat wing infiltrates. And you'll notice here that a lot of it is very central. Your traditional blunt traumas will see, let's say, broken ribs on the side and an associated lung contusion underlying it. This is the opposite for primary blast injuries. And obviously, do not be purely distracted by these things. Always be on the lookout for foreign bodies, fractures, and associated pneumothorax. Now, what do you do about these things? Patients who are asymptomatic at 6 hours probably will not develop blast lung injuries. So you can probably be discharged or move on to addressing other injuries. If you are managing a pneumothorax and a hemothorax, there is strong recommendation to consider a chest tube prophylactically before you mechanically ventilate them or transport them by air. Once you do develop blast lung injuries, unfortunately, up to 80% will end up requiring ventilatory support. And a lot of times the management strategies will defer to our ARDS guidelines, or if you're an expert at the ventilator, to individualize your management strategies. Associated with blast lung injury, similar but somewhat also different, is the concept of air embolism, which will be a little bit beyond the scope of this talk. But essentially what happens is the high pressure, you can think about it, forces bubbles of air into your circulation. And these bubbles of air can essentially serve just like a blood clot or anything to clog off your major arteries and veins. And these symptoms are very difficult to catch because they can range from anything from nausea, vomiting, joint pains, all the way to cardiac abnormalities and MI to stroke-like symptoms. If recognized, these patients require hyperbaric oxygen therapy, which is not available in every institution. All right, abdominal barrel trauma. These things, again, pressure wave, they are very wide-ranging. You can get a hematoma on your wall, your intestines or bladder can blow out, your mesentery can shear, and you can develop bleeding in all sorts of places. But most importantly, your liver and spleen, even though they are traditionally known as solid organs and don't have the traditional air or fluid-filled cavities that are able to expand and contract, can rupture. You have to maintain a high index of suspicion, and you'll hear me say this about a lot of blast injuries that are unique. You have to be on the lookout for them. You have to be aware that they're in existence. So a lot of these can present in a fairly delayed fashion. So keep an eye out for it. One more that is important in blast injuries are ocular traumas. So this can be seen in about 10 to 28% of blast injury survivors. And predominantly, you get something called an open globe injury, which is when your eye is, well, the wall is no longer intact and things are maybe leaking out, as well as intraocular foreign bodies from, again, the fragmentation that is thrown. The approach to ocular trauma, we're trauma surgeons, we're not ophthalmologists. So in the emergency bay department, what we typically do is a very simple gross visual acuity. This is not the time to pull out your Snellen and eye charts and do an eye exam. Briefly speaking, you want to ask the patient if they're able to, is their vision intact? Is it decreased? And if it's decreased, can they count fingers? Can they only see your hand move? Can they only see lights? And can they see nothing? You want to examine the pupil for any irregularities or relative afferent pupillary defects. And you want to examine their extraocular movements. If there's any injuries around the eye, on the brows or near the faces, maintain a high index of suspicion for such an injury. How do you manage these? Well, the good thing is you don't. You typically consult ophthalmology who will come in and take care of these patients. These are typically considered lower priority injuries compared to a lot of life-threatening things, but once the patient survives, I think a lot of us will agree that vision is a fairly important sense to a lot of us. So do consult ophthalmologists early on. Most open globe injuries are recommended to be repaired within 24 hours if possible to lead to better outcomes. Do not attempt to remove any intraocular foreign bodies. On this picture, you may be tempted to see, oh, there's a little fragment of something in the eye here that I'll remove, but that is not actually a fragment. That is a piece of the pupil that has herniated through a hole in the wall of the eye. So trying to pull that out will probably cause your ophthalmologist to be very upset. But what you can do, though, is a lot of damage control. And the main things are to avoid pressure on the injured eye. So you don't want to press it. You don't want to examine it too hard. You don't want to squeeze it. And if the patient's having a lot of nausea and coughing, you want to avoid any Valsalva maneuvers if possible by controlling their symptoms. And don't even wash out their eyes. Avoid any topical eye solutions. Leave it alone and protect it. Give these patients tetanus and antibiotics, and then cover the eye with either a rigid eye shield, which you can fashion out of a styrofoam cup and tape. And if the patient has to move their eyes for some reason or can't stop them from moving, cover both eyes to make them stop looking at things. All right, so that was most of the unique injuries to blast injuries. So let's talk a little bit about an incident that happened close to home. Home for me is Chapel Hill. Now, 2019 Durham gas explosion. I'm not sure how many of you know about this. There's a very talked about at my time at Duke. On April 10th, 2019 in Durham, there was a small, sleepy coffee shop here in the morning. And then at 10 a.m., a report of a massive explosion that essentially almost leveled the city block. And almost immediately, you get fire department and law enforcement at the scene try to put out the fires and get people safely out. So immediately at Duke, they set up a security and decontamination triage location, as you can see here. What's not pictured here is beyond the perimeter, there will be a lot of security and law enforcement for the reasons that we talked about before. Right outside the trauma bay is a decontamination and triage area for the anticipated mass casualty event. And these are all other pictures of what it looked that day. There's a lot of chaos, way too many people, but there's not a lot of blast injuries happening in Durham. So this is an event that will be down in memory for a lot of people. So within the first 30 minutes, we had about 6 patients show up. And these are the injuries that are reported on the top. The first patient began showing up 13 minutes after the blast injury with testicular shrapnel, and then some of the more severe ones, as you can see here, the intracranial injuries, the burn injuries, temporal bone fractures, all sorts of other fractures, cardiac arrest. This patient ended up transferring to UNC as the only burn center in the location. The next patient here had a globe rupture, an ocular injury, mangled upper extremities, and this patient was transferred to UNC as well. My wife actually ended up taking care of this patient. She's a retina surgeon. The fourth patient likewise had subarachnoid hemorrhages. Remember when we talked about these are very common injuries, a lot of fractures, an open skull fracture. This patient was transferred as well, but unfortunately didn't make it. The last ones were a combination of burns and pneumothorax and other fragmentation injuries. The second wave of injured patients began arriving several hours later, and thankfully they were all relatively mild and probably some middle ear injuries. Most of these patients had tinnitus, decreased hearing, and all could thankfully be discharged home fairly quickly. So what we think happened in that gas explosion was that at the local coffee shop, there was a gas leak that was reported for about an hour, thought to be caused by a breach in the gas line from nearby construction. Now, the source of ignition was unknown, but it's not hard to imagine that with a coffee shop nearby, there's a lot of open flames and other heating materials that could have sparked the explosion. And finally, after about an hour of gas leak, the explosion did occur. And unfortunately, this incident, even though it was very localized and was not a deliberate attempt at leveling a whole city block, did result in 2 fatalities as well as 25 injuries, including 9 firefighters. And essentially all of the local buildings in that area were completely destroyed. There were even reports of windows being shattered about 2 miles away from the site of explosion. So in summary, blast injuries, they're rare, they're unpredictable, and they really overwhelm any, especially the most prepared ones. It is one of those injuries that a lot of people may go their entire careers without seeing one, or it can even happen in a small town like Durham, which we don't expect the blast injuries to occur. We talked about the primary, secondary, and tertiary blast injuries today, which are respectively caused essentially by the time to explosion, your shock wave, your projectiles, and your wind displacements. I think I want to give people the understanding that blast trauma casualties, they're severe, they're complex, they're multimodal. You got to get all the resources on board quickly. And really, there's a couple of these unique injuries that we talked about today, from the tympanic membrane ruptures, the lung injuries, and the eye injuries, for which you really have to maintain a high index of suspicion and be not only aware that these injuries exist, but that they can present in a delayed fashion. So always keep an eye out for those. And really, that was the crash course for blast injuries. Thank you all for your time, and I think we're very much ahead of schedule, so I don't want to take all of your time, and I hope you enjoy the talk. Thank you for coming.
Well, thank you, Dr. Lau. Are there any questions from the audience right now?
I'm just curious how, after the incident was done, how did they round on those patients? Did they have any, like, did they have to come together and do multidisciplinary rounds on all the same patients if they were admitted? How did they handle that? Like, just organization and coordination of that?
You mean like the day after, for example?
Yes.
I think thankfully, these numbers of casualties did not overwhelm the local resources. You know, both UNC and Duke are level 1 trauma centers with a lot of resources. So as far as I know, it was business as usual. People just rounded on them. Trauma surgery rounded on them. ICU rounded on them. All the consultants rounded on them. I hope that answers your question.
Yes, thank you.
Scott Wilson?
You mentioned Duke and Chapel Hill. Do you feel like there, in these type of injuries, there's going to be a lot of collaboration between the different centers? Quite a bit of specialties mentioned, ophthalmology, urology, so on, in these injuries. There's only so many to go around.
Yeah, I think the triangle is uniquely positioned as having 3 level 1 trauma center within 30-minute driving distance to each other. So I'm not sure this is going to be something that's potentially applicable for a place like Charlotte, which we only have really 1 level 1 trauma center, and we don't have a burn center. So I think if you were to have a blast injury, Durham was a pretty fortuitous place to have it. I don't know how the logistics of that would work in a place like Charlotte region, but we do have a couple of level 3 trauma centers, including myself at Cabarrus, that would be able to offload some of the mild to moderately injured patients for sure.
I see a hand raised. I can't. Dr. Miles.
Dr. Lau, that was excellent presentation as always. I love your presentations at MTAC and other educational venues.
Thanks,
One
Dr.
question,
Miles.
one quick question, because I know we have a very robust hazmat team that practices as part of MTAC, as part of our Med Center Air and other teams to understand and prepare for those other hazardous chemicals and potential for radiation and other things. But in a blast effect like what happened in Durham and Chapel Hill areas, often you don't get as much time to prepare for, and some of those patients will go to other hospitals. Do you have any recommendations for referral hospitals and others to more rapidly prepare for disaster blast like ones that happened in Chapel Hill and Durham?
Well, thanks, Dr. Miles, for your kind comments and question. I just want to start off by saying I'm not an expert in mass casualty planning, but I will say there's what's not shown here is there was actually quite a few patients that were triaged and sent to Duke Regional Hospital, which is a much smaller hospital and not a trauma center. And one of the issues there on a review of this incident in the post-incident reports was that the triage, decontamination, and security area at Duke Regional was much less robust, or rather non-existent. I don't remember what Charlotte's bay outside of the trauma bay looks like, but at Duke at UNC, what they have is these large showers right outside of the trauma bay. And these are preemptively set up to allow rapid decontamination if necessary. The other thing to consider in this specific incident is that the information we were able to obtain at the time did not suggest any CBR-related threats, because there was reports of a gas leak for about an hour or so. And so when the explosion happened, the presumption was that this was a gas-related explosion and not a terrorist attack with CBR threats. I don't know how they would have mobilized the resources if it had been, let's say, during a marathon or something that was more suspicious for a terrorist attack. Oh, Scott, you had your hand up?
Yes, a follow-up question, kind of alluding to Dr. Miles' question. In a lot of events like this, many of the patients arrive POV, and with a large metropolitan area like the Charlotte region or in the Triad area, there are a lot of other hospitals, like you just said, that are not trauma centers. Do you feel like that might overwhelm them? Do they refer back over to the trauma center? People are going to go where they think they're going to get help the quickest.
And this is actually a very interesting phenomenon in mass casualty event. It's something known as the reverse triage effect, where occasionally your least injured patients will end up showing up to your trauma bay first. This was actually somewhat seen during the Las Vegas shooting, where some of the least injured patients who are able to move or get into the car, will drive themselves to the nearest trauma center, the nearest hospital, before the arrival of the truly severely injured people who require EMS stabilization. So my answer to that is, if there is a reverse triage effect and you recognize it happening, it's possible that these patients are, generally speaking, not the most injured. And we could potentially follow the triage guidelines of, look at their tympanic membranes. If they're fine after a couple of hours of observation, even in any remote emergency departments, they're probably going to be fine. It's really the patients who show up after the first POV patients that we really got to be worried about. Does that sort of answer?
Yes, very much so. Thank you.
Thank you.
Great, excellent response. Any other questions out there?
Do we have a big shower at the CMC to decontaminate people? I'm just curious. I don't remember seeing one.
Yeah, it's actually, there's a small room right as you're coming into the major ED major sliding doors right there.
Gotcha.
Very interestingly enough, in 2012 we had a mass casualty drill where it was the idea was a chemical spill and a train crash, and we had well over 100 patients, and these were divvied up throughout the region, and part of it was a decontamination process. And one of the things that was learned from a number of places, that the decontamination, like any practice, you can do tabletops all you want, but you actually do have to do the practice, because one of the things they found out is there was a leak in the decontamination room.
Oh, no.
in the ED major. So what happened is, as they were washing the patients down, the effluent was leaking into the ED major, and if that was a true contamination, we would have had to shut down the entire ED major, which would have been a disaster in a disaster.
Wow.
And a number of other programs had their decontamination tents set up over 100 feet from the ED doorways, which they thought was safe, but the problem is they were uphill. So what was happening is all the effluent was running downhill to the ED driveway. So there's a lot of preparedness here that's much more that you don't think about unless you actually do it. But there's a fair amount of disaster preparedness here. It's probably time for us to do a real encore drill for something like this as well, because this, as Dr. Tom Blackwell said in 2000, it's not a matter of if, it's really just a matter of when. So and no matter how much you prepare, you're never quite as prepared as you like to be.
No, especially something this
So,
rare.
Yeah, I do see another hand out there. Dawn Middleton.
Hey, thank you. Hey, Dr. Lau. I have a question around ophthalmology resources.
Yes.
You mentioned several times regarding getting those folks involved early on, and ENT in that. Just wondering, I just don't know what our bandwidth is, obviously in this area. Did you have any issues with that in your experience, or how do you mobilize those folks?
That's a very good question. I think what's unique about my experience in Charlotte at Cabarrus is that the ophthalmologists are generally, correct me if I'm wrong, but at least at Cabarrus, they're not affiliated with Atrium Health. They are private practice people that get contracted to cover call as well as operate at the hospital. But there's supposed to be someone on call, and you're supposed to be able to reach them at any time. The unique thing at Duke, well, it's not unique, but the thing at Duke and UNC is that the ophthalmologists are all employed by the university, and they're being teaching institutions. They have several layers of fellows, residents, and so a lot more available ophthalmology resources for that reason. And the thing is, ocular trauma definitely is not life-threatening, but it is something that people care a lot about their vision, for sure. The only times you would potentially not need to consult them is if there's an eye injury and the patient's not expected to survive. So obviously, then that can help kind of down triage some of the need for their resources. But anyone who's expected to make it, even if they're intubated in the ICU with an open abdomen and really sick, you should get ophthalmology involved because they need to fix that eye as quickly as possible. And the reason is because the eye is an immunologically privileged organ in that it's not used to being with the outside world. It's like the most introverted organ you can find. And so the moment it interacts with the outside world, it gets infected. And once your eye gets infected, you're pretty much guaranteed to go blind. And so that's the reason why time is important. But overall, the sad reality is these open globe injuries with fragments, they do very poorly, regardless of how quickly you get to them.
Thank you.
Thank you.
Scott, got your hand up again?
To piggyback on Don's question, in seeing a large number of these eye injuries and only so many specialists that are in short supply, is there a magic pot of federal assets? Like, is there like military resources? Who do you call when you've got 100 eye injuries?
Oh, I don't know about that. Well, if my wife's visiting me in town while I'm working, you can call her. But short of that, I don't know how to address that. And I think you guys can correct me. What is the situation with ophthalmology at CMC? Is it also like a contracted private practice group?
Yes.
Okay, I guess one option is to reach out to other private practice in the area and see if you could get them to, for the ambulatory patients to get them seen quickly, or if any of them are willing to even come in-house. But then you have to work about privilege issues and all these things. It's a challenge for sure.
So I was going to add, we are working a lot with Wake now, Dr. Lau, now that we're all one. But ophthalmology resources, can be challenging here. Which is what prompted my question. I mean, we do have them. We do have it available, but that's what just got me thinking. Listening to this, that and ENT is fairly responsive though.
Gotcha. So. Do any of them come all the way down from Wake Forest, or are they still pretty much?
No, we send most of them out. I mean, I would defer to some of the physicians on this, but my experience in the emergency department is we do send most of those out. They don't come here.
Gotcha. Well, thank you all so much for your questions. I really loved talking about this.
Great interactions, Dr. Lau. Thank you for presenting, and we hope to get you back and speak in the future for us.
Thank you so much for all being here and taking time. I really appreciate it.
Thanks.
Thanks, everyone. Have a great day.
Take care. Have a great day.